Hello, everyone. My name is Cortney Rinker, and I am the director of the Global Affairs program here at George Mason University. And I am also associate professor in the Department of Sociology and Anthropology. Thank you for inviting me to be part of the conference, The New Normal. And today I'm going to be thinking a little bit about what will aging, death, and dying look like in the new normal. So I'm going to open my talk today by describing two distinct scenes for you. The first is a photograph taken by the driver of a car while he was sitting behind the steering wheel. His car is parked in a large parking lot that is filled with vehicles. He snapped a photo of the large brick building at the edge of the parking lot. It is several stories tall with many small windows. In the front of the building, there are red capital letters, very large, on an overhang that spell emergency. This is a photo that I came across on my newsfeed on Facebook during the earlier months of the COVID-19 pandemic. This is when the hospital started to limit the number of visitors or ban all visitors together in order to try to protect their employees and patients from the virus. The photo was posted by a friend who I had grown up with in my hometown. The caption read, and I will paraphrase here, that he and his mother were unable to enter the hospital to visit his father, who was dying from cancer. They instead had to wait in the parking lot. They hoped they would not receive the call to tell them that his father had died alone in his hospital room, maybe with a nurse or a staff member, but not with his son and wife. My friend then went on to warn everyone that COVID-19 was, quote, no joke, and that we all must take it seriously. This was still at the point when people were unsure of what was happening and of the severity of the virus. He said that if we don't, we may be waiting in the parking lot, unable to be with a loved one, as they suffered from the respiratory distress and other symptoms and complications associated with the novel coronavirus. The second is a scene from before the pandemic. It is a man in his 80s lying in his hospital bed. On this visit, he is awake. He has an IV and several wires are coming out from underneath his hospital gown. They are connected to a monitor that is next to his bed. Different color lines run across the screen in what resembles a pattern of mountains with peaks and valleys. I remember this image very well in my mind. It was from when I was conducting fieldwork at a hospital on the experiences of diverse Muslim patients, families, and healthcare providers as they interacted with the healthcare system during times of serious illness and terminal illness. As I walked towards the monitor, the physician I had shadowed that day turned to me and said, "Do you see those lines? That is his pacemaker. His heart isn't beating anymore on its own." The pacemaker provoked and regulated the man's heartbeat. Without it, he most likely would not have survived very long. I spoke briefly with the man as he was quite tired. I looked at him as he laid in his hospital bed, but as I walked out of the room, I thought to myself, was I really looking at a human being, given the device was controlling this vital part of his body? Was he really living in the way that we usually define living or being alive? These are two very distinct scenes. The first is of a son as his father dies alone in a hospital room, and the other is of a man whose body is being kept alive by a small electronic device that was surgically inserted into his chest. This talk is speculative, as I do not claim to have any answers. I may actually leave you with more questions to ask yourself. What I want to do here is to point out a paradox that has become acutely visible during COVID-19 and think about how it may impact what aging, death, and dying will look like as we move beyond the pandemic, although I'm not particularly sure I know what post-pandemic means just yet. I see elements of both of these scenes as being part of our new normal, particularly here in the United States. COVID-19 is a new infection with serious complications that have overwhelmed many healthcare systems around the world. News stories surfaced of physicians in Italy, one of the first epicenters of COVID-19, having to direct critical yet scarce resources to patients who would benefit the most from treatment. The city in South Korea with the most COVID-19 cases reported having a shortage of hospital beds, leaving people to die at home while waiting for one to open. New York City had a difficult time keeping up with the number of dead bodies during the first part of the pandemic. We saw images of freezer trucks pulling up to the loading docks of hospitals to store the dead bodies. My guess is that given the sheer magnitude and spread of COVID-19, growing older, dying from natural causes or disease, and death itself will not unfold like they have in the past in the United States and elsewhere, at least not in the near future. So let me get back to the paradox that I had mentioned a moment ago. What is striking to me is that during the pandemic, is that in general, we have had to rely on technology more than we have had to rely on it in the past in our daily lives. I was at Wawa, which is a chain of convenience stores located here in the Eastern region, the other day, and I found that the soda machine has a QR code that would allow you to dispense your soda by using your phone instead of actually touching the machine, as a way of cutting down the possibility of transmitting the virus through a high-touch surface. This also assumes that we all have smartphones. A local Walmart in Northern Virginia, as well as others around the country, have transitioned to being all self-checkout. There are no more human cashiers. They've transitioned to other roles in the store. Smart technologies in particular have enabled us to remain connected to others during the pandemic, even though we could not physically be with them, such as holding virtual celebrations and events, conducting meetings with colleagues over Zoom, instructing or taking classes online, and video chatting with family and loved ones who are in nursing homes and other long-term care facilities. Technology has provided us the means to remain connected and offered us creative ways to continue on with our lives to the best of our abilities in spite of the pandemic. Nevertheless, the dependence on technology during the pandemic lends itself to the question of whether we may have overused or relied too much on healthcare technologies before 2020, and if so, what are the consequences? Anthropologist Nancy Shepherd-Hughes notes that Americans are anxious about, quote, where and how they will live out their final days. She links this anxiety to discursive and institutional shifts that have occurred in the United States, most notably capitalism and neoliberalism, as well as the wider availability and accessibility of healthcare and medical technologies, which has subsequently led to the view of death as a failure that could have been prevented. Shepherd-Hughes observes that historically, death was once seen as an ordinary and expected part of everyday life, but more so, it is now seen as something that should not happen, quote, banished from polite society and denied, end quote. This shift in how death is thought of and experienced in the US stems above all from the development of medical interventions and technologies whose main purpose is to prevent death and sustain life, along with changes in where death was actually taking place, more often now in medical facilities rather than the home, although we do see some shifts in these statistics as well. Sharon Kaufman, a well-known scholar in the anthropology of aging, notes that the medicalization of death, frequently coupled with attitudes and fear towards pain, creates an implicit obligation to medically intervene in the dying process, especially given the advancement in technology and the numerous life-saving and life-sustaining measures that are available. Death can no longer happen naturally or be dictated by solely the human body. But COVID-19 did not spare anyone. It was not expected. People of all ages died, although we do see that those who are older died at higher rates than younger, and we do see disparities in terms of class, ethnicity, and race as well. We have read about healthy people ending up on a ventilator for days, if not weeks, after contracting the novel coronavirus. Some recovered, and some unfortunately did not. Will COVID-19 prompt us to talk more openly about death and dying, something desperately needed? Will it cause us to think more about what treatments and life-saving and sustaining measures that we do and do not want as our final days approach? I'm reminded of the public and political outcry in 2009 and 2010, over the inclusion of a policy in the Affordable Care Act that would allow physicians to be reimbursed by Medicare for discussing end-of-life options with patients. Sarah Palin, the 2008 U.S. vice presidential nominee and former governor of Alaska, used the term death panels. And Palin suggested that these panels, made up of bureaucrats, would make a judgment about someone's worth in society, which would in turn influence the type and level of care a patient would receive. The controversy over death panels, which President Barack Obama denied would exist under the new healthcare bill, caused it to be removed from the proposed legislation that would restructure the healthcare system. However, the Obama administration was able to enact the new rule starting on January 1st, 2011, that allows for a discussion on advanced care planning to be part of a yearly visit to the doctor. And they did so partly drawing on academic research and literature showing that this has benefits for the patient and their families or loved ones. When I conducted my fieldwork at the hospital on end-of-life care, I noted that while the physicians and healthcare providers, like nurse practitioners, worked hard to understand and respect the wishes of their patients and or their loved ones, depending if the patients were able to speak for themselves, sometimes they would disagree with the choices that the patients or families were making about the use of medications, surgeries, or life-saving and sustaining technologies because they believed that they may have crossed the line ethically, inflicting more harm than good on the patient's bodies and their well-being. I acknowledge that death is not universal in terms of how, when, and where it happens. Neither is aging. It is culturally and geographically situated. Furthermore, while everyone will die as a biological fact, even biology is culturally constructed and locally specific. Humans in every part of the world are biologically and physiologically similar, but anthropologist Margaret Locke suggests that it is important to think in terms of, quote, local biologies, which reflect the very different social and physical conditions of people's lives from one society to another, which also means that the aging experience and growing older won't be experienced the same way by everyone. So even a life event that we will all experience, death, will not physically be the same. Death is ultimately an unavoidable topic. And I believe that people are much more than statistics, so please forgive me here. But I will close with a question. Have the millions who have died or been infected finally caused us to think more about and to communicate more about our final days and what we do and do not want in terms of treatment and interventions? Thank you very much for your time.